Group 2 3B2 Presenting Trauma and Stress-Related Disorder. Trauma and stress-related disorder involve exposure to a traumatic or stressful event. The three of the trauma-related disorders: post-traumatic stress disorder or PTSD, acute stress disorder, and lastly, adjustment disorder. A stressor can be any event either witnessed firsthand, experienced personally, or experienced by a close family member that increase physical or psychological demands on an individual. A stress disorder occurs when an individual has difficulty coping with or adjusting to a recent stressor. Post-traumatic disorder, more commonly known as PTSD, is identified by the development of physiological and psychological and emotional symptoms following exposure to a traumatic event. Examples of these situations include but are not limited to: A. Witnessing a traumatic event as it occurred to someone else. B. Learning about a traumatic event that occurred to a family member or close friend. C. Being exposed to repeated events where one experiences an adversive event. It should be understood that while the presentation of these symptoms varies among individuals, to meet criteria for diagnosis of PTSD, individuals need to report symptoms among the four different categories of symptoms. Number 1. The first category involves recurrent experiences of the traumatic event. This can occur via flashback. Distinct memories may be voluntary or involuntary or even distressing dreams. In order to meet criteria for PTSD, these recurrent experiences must be specific to the traumatic event or the moments immediately following. Regardless of the method, these recurrent experiences can last as short as several seconds or extend for several days. Number 2. Involves avoidance of stimuli that is related to the traumatic event. Individuals with PTSD may be observed trying to avoid distressing memories of the traumatic event. One way individuals will avoid these memories that trigger the memory to the traumatic event. Number 3. Experienced by individuals with PTSD negative alterations in cognitions or mood.
It should be noted that this amnesia is not due to a head injury, loss of consciousness, or substances but rather due to the traumatic nature of the event. The fourth and final category is alteration in arousal and reactivity. Because of the negative mood and increase of irritability, individuals with PTSD may be quick-tempered and aggressive manners both verbally and physically. Duration of symptoms also important, as PTSD cannot be diagnosed unless symptoms have been present for at least 1 month. If they have not been present for a month, the individual may meet the criteria for acute stress disorder. Acute stress disorder. This is very similar to PTSD except for the fact that symptoms must be present from 3 days to 1 month following exposure to one or more traumatic events. Acute stress disorder requires that the individual experience 9 symptoms across the 5 different categories. Intrusion symptoms, negative mood, dissociative symptoms, avoidance symptoms, and arousal symptoms. Adjustment disorder occurs following an identifiable stressor that has occurred within the past 3 months. This stressor can be single event, loss of job, death of family member, or a series of multiple stressors. Cancer treatment, divorce, child custody issues. Due to the variety of behavioral and emotional symptoms that can be present with an adjustment disorder, clinicians are expected to classify a patient's adjustment disorder as one of the following: with depressed mood, anxiety, mixed anxiety and depressed mood, disturbance of conduct, mixed disturbance of emotion and conduct, or unspecified for behaviors that do not meet criteria for one of the aforementioned categories.
Etiology: biological, cognitive, social, cultural. Biological: one theory for the development of trauma and stress-related disorder is the over-involvement of hypothalamic-pituitary adrenal HPA axis.
The HPA axis is involved in the fear-producing response, and some speculate that the dysfunction within this axis is to blame for the development of trauma symptoms.
In the brain, the amygdala serves as the integrative system that essentially elicits the psychological response to a traumatic, stressful environmental situation. cognitive. Pre-existing condition of depression and or anxiety may predispose an individual to develop PTSD or other stress disorder. Social. While this may hold true for many psychological disorders, social and family support have been identified as protective factors for individuals prone to develop PTSD. Sociocultural. There is some evidence to suggest that cultural groups also interpret traumatic events differently and therefore may be more vulnerable to the disorder.
Treatment. Psychological debriefing. Psychological debriefing is considered a type of crisis interventions that requires individuals who have recently experienced a traumatic event to discuss or process their thoughts and feelings related to the traumatic event, typically within 72 hours of the event. Few different methods to a psychological debriefing. Number 1, identifying the facts. Number 2, evaluating the individual thoughts and emotional reactions to the events leading up to the event, during the event, and then immediately following. And number 3 is normalizing the individual's reactions to the event. This is predominantly used in anxiety disorders. It has also shown great assistance in PTSD-related symptoms as it helps individuals distinguish fears associated with traumatic events. Different types of exposure techniques are imaginal, in vivo, and flooding are among the most common types. Trauma-focused cognitive behavioral therapy. An adaptation of CBT that utilizes both CBT techniques as well as trauma-sensitive principles to address the trauma-related symptoms. TFCBT can be summarized via the acronym practice. Psychoeducations about traumatic event, relaxation training, affect, correcting negative or maladaptive thoughts, trauma narrative, in vivo exposure, causing familiarization, and enhancing security. Psychopharmacological treatment. Interventions have been shown to provide some relief, particularly to veterans with PTSD. Most clinicians agree that resolutions of symptoms cannot be accomplished without implementing exposure and cognitive techniques that target the psychological and maladjusted thoughts containing the trauma symptoms.